Critical Assessment of Surgical Outcomes and Health Services Research, Q&A. Welcome to today's podcast, where we discuss critical assessment of surgical outcomes and health services research. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in understanding research. Pause the podcast after each question to attempt answer. Let's begin. Question: what is a common challenge surgeons face when engaging with research evidence? Answer: a common challenge is critically evaluating the literature and then applying findings from health services research and surgical outcome studies to day-to-day surgical decision making. Question: what is the overall goal of this chapter on surgical outcomes and health services research? Answer: the goal is to provide a clear framework for critically appraising surgical outcomes research and health services research, so surgeons can judge evidence quality and use it appropriately in practice. Question: what topics and methods will the chapter focus on to help readers assess surgical evidence? Answer: the chapter focuses on methods for assessing the strength of evidence, establishing the validity of surgical studies, and applying principles of evidence-based medicine to clinical decision-making. Question: how has surgery changed over the past century, and what has driven that change? Answer: surgery has evolved substantially over the past century, largely because new scientific evidence has clarified which approaches are safest, most effective, and most appropriate for specific patients. Question: why is an evidence-based practice approach important in surgical care? Answer: an evidence-based practice approach is essential because it relies on careful evaluation of surgical research, helping clinicians apply trustworthy findings to real clinical decisions and improve patient outcomes. Question: what does the term critical appraisal mean in the context of surgical research? Answer: critical appraisal is the careful and systematic examination of research evidence to judge its validity, its value, and its relevance to a specific clinical context. Question: what factors should guide decisions in surgical care? Answer: surgical care decisions should be made by thoughtfully integrating patient preferences, clinical experience, and a critical appraisal of the best available evidence. Evidence-based approach to surgery. Question: what principles guide evidence-based medicine when making surgical decisions? Answer: evidence-based medicine starts with an awareness of the best available research evidence, uses clear standards to judge whether that evidence is trustworthy, and weighs expected benefits against risks, burdens, and costs while also considering each patient's individual circumstances. Question: what is the step-by-step approach used when practicing evidence-based medicine? Answer: the approach is often described in 5 steps. Ask a focused clinical question, acquire the best available evidence, appraise the evidence for quality and relevance, apply the evidence in the context of the individual patient, and assess the outcome to improve future decisions. Question: why is evidence-based medicine especially important for surgeons? Answer: it is important because surgeons must consistently make high-stakes decisions, and an evidence-based approach helps them provide high-quality patient care by relying on the most trustworthy research rather than habit or opinion. Question: how does evidence-based medicine influence surgical practice? Answer: it shapes how surgeons decide when procedures are indicated, which management approaches are appropriate, and how surgical care is delivered across the entire patient pathway. Evaluating scientific evidence in clinical practice. Question: how can surgeons use the population, intervention, comparator, outcome, and time framework to apply scientific evidence in clinical practice? Answer: surgeons can use this framework to organize their literature review, clarify the research question being asked, and decide whether the evidence fits the clinical situation they are treating. Question: what is the purpose of the population, intervention, comparator, outcome, and time framework when summarizing and appraising scientific evidence? Answer: it provides a structured method for summarizing the key parts of a study, judging the strength of the evidence, and interpreting what the results mean for patient care. Question: how can surgeons use the population, intervention, comparator, outcome, and time framework to judge whether a surgical outcome study is relevant to their own practice? Answer: it helps them compare the study population to their patients, evaluate whether the intervention and comparator match realistic options in their setting, confirm that the outcomes measured are clinically meaningful, and ensure the time frame fits the decision they need to make. Question: what does the population, intervention, comparator, outcome, and time framework stand for, and how does it help clinicians? Answer: it stands for population, intervention, comparator, outcome, and time, and it helps clinicians judge both the validity of a study and how relevant its findings are to everyday clinical practice. Study design. Question: what types of study designs are commonly used in surgical research? Answer: surgical research commonly uses both experimental study designs and observational study designs, depending on the question being asked and the practical constraints of the research setting. Question: what practical factors often influence the choice of a study design in surgical research? Answer: practical considerations such as resource availability, staffing, time, ethics, and overall feasibility often shape which study design can realistically be used. Question: how does the chosen study design affect confidence in cause and effect conclusions about surgical interventions? Answer: the study design strongly influences how confidently researchers can claim that an intervention caused an outcome, because some designs control for bias and confounding more effectively than others. Question: what criteria must be met to support a causal relationship in surgical research? Answer: to support a causal relationship, the cause must occur before the effect, the cause must be related to the effect, and there must be no other plausible explanation for the effect besides the proposed cause. Question: what are the Bradford-Hill criteria, and why were they proposed? Answer: the Bradford-Hill criteria are a set of 9 considerations proposed in 1965 to help establish epidemiologic evidence that supports a causal relationship between an exposure and an outcome. Question: which study designs are generally considered to provide the highest level of evidence in surgical research? Answer: prospective and randomized experimental studies are generally considered to provide the highest level of evidence because they are designed to best support cause and effect conclusions. Question: why is it important to understand the strengths and limitations of different study designs when evaluating clinical evidence? Answer: understanding the strengths and limitations of each study design helps clinicians judge how much trust to place in a study's findings and how appropriately those findings can be applied to patient care. Question: can even well-designed studies lead to incorrect conclusions? And if so, why? Answer: yes. Even a strong study design can produce incorrect conclusions if the study is not executed carefully or if the data are analyzed analyzed improperly, because errors in implementation or analysis can distort the true relationship between intervention and outcome. Randomized controlled trials question. How is a randomized controlled trial designed in surgical research? Answer. In a randomized controlled trial, patients are assigned by chance to either a treatment group or a control group before the intervention begins, which helps ensure the groups are comparable at the start. Question. Why are randomized controlled trials often described as the gold standard for evaluating healthcare interventions? Answer. They are often considered the gold standard because random assignment reduces selection bias and strengthens confidence that differences in outcomes are caused by the intervention rather than by pre-existing differences between groups. Question. What variations of randomized controlled trial design can expose participants to more than one intervention? Answer. Factorial designs and crossover designs can allow exposure to multiple interventions, either by testing combinations of treatments or by having participants receive interventions in different sequences over time. Question. What is the main advantage of a randomized controlled trial when determining whether an exposure causes an outcome? Answer. A randomized controlled trial is especially strong for determining causation because random assignment helps isolate the effect of the intervention from other factors that might influence outcomes. Question. How does randomization reduce selection bias and support estimation of treatment effects? Answer. Randomization tends to balance both known and unknown prognostic factors between groups, which minimizes selection bias and makes differences in outcomes more likely to reflect the true treatment effect. Question. How does randomization support blinding in a randomized controlled trial? Answer. Because assignment is determined by chance, randomization can make it easier to keep treatment identity hidden from investigators, participants, and outcome assessors, reducing the risk that expectations influence measurements. Question. In surgery, what kinds of interventions can randomized controlled trials compare? Answer. They can compare a wide range of surgical interventions, including operative procedures, medicines, screening programs, and diagnostic methods. Question. What are common limitations of randomized controlled trials? Answer. They are often expensive and time-consuming, and they may not generalize well to everyday practice when strict enrollment criteria exclude many real-world patients. Question. Why can randomization be especially challenging in surgical randomized controlled trials? Answer. Randomization can be difficult because of ethical concerns, patient reluctance to be assigned to an operation by chance, and the complexity and variability of surgical techniques and surgeon experience. Question. What is the purpose of the Consolidated Standards of Reporting Trial Statement? Answer. Its purpose is to provide guidance for reporting randomized controlled trials in a way that supports transparency, completeness, and validity. Question. What does the Consolidated Standards of Reporting Trial Statement include for reporting randomized controlled trials? Answer. It includes a 25-item checklist and a flow diagram, with an emphasis on reporting two parallel group trial designs. Question. How does the Consolidated Standards of Reporting Trial Statement help surgeons assess the quality of evidence? Answer. It gives surgeons a consistent set of reporting expectations to look for, making it easier to judge whether a trial is described clearly enough to evaluate its methods, risk of bias, and overall reliability. Cross-sectional study question. What is the basic design of a cross-sectional study? Answer. A cross-sectional study observes research participants at a single point in time. Question. How are exposure and outcome data collected in a cross-sectional study? Answer. Exposure and outcome data are collected at the same time. Question. How are participants typically selected or compared in a cross-sectional study? Answer. Participants are often similar in most respects but differ in a key characteristic of interest, such as age, income, or location. Question. What are cross-sectional studies commonly used to describe in community or hospital settings? Answer. They are commonly used to describe disease prevalence or to describe characteristics of a population in a community or hospital setting. Question. What are the main advantages of cross-sectional studies? Answer. They are usually inexpensive and are often used to explore possible relationships or to gather preliminary data for future studies. Question. What are the main limitations of cross-sectional studies? Answer. They can be limited by survival bias. They cannot analyze associations over time, and they may be subject to sampling bias. Case control study question. What is the basic design of a case control study? Answer. A case control study compares individuals who have a specific outcome, called cases, with individuals who do not have that outcome, called controls. Question. How do researchers assess exposure in a case control study? Answer. Researchers look back and measure how often past exposures occurred in both the cases and the controls. Question. If cases have a higher frequency of exposure than controls, what does that suggest, and what does it not prove? Answer. It suggests there may be an association between the exposure and the outcome, but it does not, by itself, prove that the exposure caused the outcome. Question. What are the main strengths of case control studies? Answer. Case control studies are well suited to examining uncommon outcomes, exploring multiple potential risk factors, and considering long-term effects. They are also relatively inexpensive and are often used to generate hypotheses for future research. Question. What are the main limitations of case control studies? Answer. Because they look back in time. Case control studies are more prone to recall bias and selection bias. They can also be limited by difficulty identifying a valid control group, by imperfect estimation of past exposures, and by the fact that they typically focus on one outcome at a time. Cohort study question. What is a cohort study in the context of surgical outcomes research? Answer. A cohort study is an observational study design that compares groups based on their exposure to a risk factor. Question. What is a prospective cohort study, and how is it conducted over time? Answer. A prospective cohort study is planned in advance and follows exposure groups forward in time to measure the incidence of outcomes as they occur. Question. What is a retrospective cohort study, and what type of data does it use? Answer. A retrospective cohort study analyzes existing records or databases to identify exposures and then examines how those exposures relate to outcomes that have already occurred. Question: what are the advantages of cohort studies when compared with randomized controlled trials? Answer: cohort studies are often easier and less expensive to conduct than randomized controlled trials. They allow estimation of incidence rates, and they can use matching to help control for confounding variables. Question: what are the disadvantages of cohort studies? Answer: because cohort studies do not use randomization, exposure groups may differ in ways that are not measured. Cohort studies can also be difficult to blind, and they may require long follow-up periods to observe outcomes. Question: what limitations are especially important to consider in retrospective cohort studies? Answer: retrospective cohort studies are susceptible to treatment selection bias and confounding, which can create unmeasured differences between exposure groups and distort estimated associations. Question: how is evidence from cohort studies commonly assessed for quality? Answer: evidence quality is often assessed using simplified checklist methods, such as the Strengthening the Reporting of Observational Studies in Epidemiology checklist, which helps reviewers evaluate whether key study elements are reported clearly. Question: what is the Strengthening the Reporting of Observational Studies in Epidemiology statement? Answer: the Strengthening the Reporting of Observational Studies in Epidemiology statement is a checklist that provides guidance on reporting critical components of observational studies, including cohort studies. Question: which types of observational study designs are covered by the Strengthening the Reporting of Observational Studies in Epidemiology checklist? Answer: it covers several observational study designs, including cohort studies, case control studies, and cross-sectional studies. Question: what checklist has been proposed to evaluate the quality of evidence from databases used in surgical outcomes research? Answer: a 10-item checklist has been proposed to evaluate the quality of evidence from databases used in surgical outcomes research. Question: what is the purpose of the database quality checklist in retrospective cohort research? Answer: the checklist helps evaluate findings from retrospective cohort studies and determine whether a database is suitable for answering a specific research question. Question: why is alignment between a database and a research question so important in surgical outcomes research? Answer: alignment matters because the database must capture the right patients, exposures, and outcomes for the question being asked, and missing data must be addressed using appropriate statistical methods to avoid biased conclusions. Question: what types of data sources are commonly used in surgical outcomes research? Answer: common sources include clinical registry data, such as the National Surgical Quality Improvement Program and the Surveillance, Epidemiology, and End Results Program, as well as administrative claims data, such as the National Inpatient Sample and Medicare Claims data. Question: how can the way data are collected influence research conclusions and the questions that can be answered? Answer: the way data are collected influences which variables are available, how accurately they are measured, and which patient journeys can be followed, which in turn affects both the conclusions that can be drawn and the questions the dataset can credibly answer. Question: what practical considerations should researchers review when choosing a data source for surgical outcome studies? Answer: key considerations include whether the dataset can track episodes of care over time, whether the sample size is adequate, whether patients are representative of the target population, how variables are defined, and how accurate and complete the data are. Case series and reports. Question: what has been the most common study design in surgical literature? Answer: case series and case reports have been the most common study designs in surgical literature. Question: what are the key characteristics of a case series? Answer: a case series reports observations on a group of individuals receiving the same surgical intervention, and it does not include a control group. Question: on what basis are case series typically sampled? Answer: case series may be sampled based on exposure, for example all patients who underwent surgery at a specific institution, or based on outcomes, for example patients who experienced a rare adverse event. Question: what are the main strengths of case series and case reports? Answer: they can provide an in-depth narrative and detailed clinical information, which is often useful for generating new hypotheses. Question: what are the main limitations of case series and case reports? Answer: they cannot reliably generalize findings or establish causal relationships, so they are generally considered low-quality evidence. Question: what study design characteristics limit what case series and case reports can measure? Answer: because they are non-comparative. They cannot calculate absolute risk measures or relative risk measures. Synthetic and systematic outcome studies. Meta-analyses. Question: what is a meta-analysis, and what is it designed to do? Answer: a meta-analysis combines results from multiple studies on the same topic to improve the precision and accuracy of effect estimates. Question: what are the main advantages of meta-analysis? Answer: meta-analysis increases statistical power, supports generalization to larger populations, and can help identify publication bias. Question: what underlying assumption does a meta-analysis make about the relationship being studied? Answer: it assumes there is an underlying true association between variables, and that individual studies measure that association with some degree of error. Question: what limitations can reduce the quality of evidence produced by a meta-analysis? Answer: heterogeneity across studies, such as differences in patient populations, outcome measures, or exposure groups, can limit the quality of evidence. Question: why can selection bias and confounding in observational studies affect meta-analysis conclusions? Answer: selection bias and confounding can distort the original study estimates, and those distortions can carry into a meta-analysis, undermining the validity of the combined results. Question: what does the overall quality of a meta-analysis depend on? Answer: the quality of a meta-analysis depends on the methodology used and on the potential biases present in the studies it includes. Cost-effectiveness analysis. Question: what is a cost-effectiveness analysis? Answer: a cost-effectiveness analysis is an economic evaluation that measures both the outcomes and the costs of alternative interventions. Question: how is cost-effectiveness analysis being used in surgical literature today? Answer: it is increasingly used to help contain surgical costs and to define high-value care. Question: what is the incremental cost-effectiveness ratio, and what does it tell you? Answer: the incremental cost-effectiveness ratio is the ratio of the incremental cost to the incremental effectiveness of two interventions, indicating the cost of achieving an additional unit of benefit. Question: what metric is commonly used to capture both the quantity and quality of life in cost-effectiveness studies? Answer: quality-adjusted life years are commonly used to measure both the quantity and the quality of life in cost-effectiveness studies. Question: How are quality-adjusted life years calculated? Answer. They are calculated by weighting the amount of time spent in a particular health state by the quality of life associated with that health state. Question. What threshold is commonly used to judge whether a healthcare strategy is cost-effective? Answer. Healthcare strategies that cost less than $100,000 per quality-adjusted life year are generally considered to be cost-effective. Question. What is the purpose of cost-effectiveness studies for surgeons making clinical decisions? Answer. They help surgeons make clinical decisions by presenting cost and outcome trade-offs between competing interventions. Question. What are Markov models in healthcare, and what do they simulate? Answer. Markov models simulate cost and outcome trade-offs over time under different conditions, incorporating estimates of risk and the probability of desired outcomes. Question. What are the advantages of using Markov models in cost-effectiveness analysis? Answer. They allow modeling how probabilities change over time for entering different health states and outcomes, which enables estimation of multiple scenarios to support clinical decisions. Systematic reviews. Question. What is a systematic review in surgical research? Answer. A systematic review is a rigorous method of synthesizing surgical evidence by systematically searching for, evaluating, and integrating existing studies that address a specific research question. Question. What does a comprehensive search strategy involve in a systematic review? Answer. It involves developing a detailed plan to identify all relevant studies, apply clear inclusion and exclusion criteria, evaluate study quality, and synthesize the results in a transparent and reproducible way. Question. Which online databases are commonly used to carry out a systematic review search strategy? Answer. Searches are commonly executed using the Medical Literature Analysis and Retrieval System Online, the Excerpt to Medica database, the Cumulative Index to Nursing and Allied Health Literature, and the Cochrane Library. Question. Why are systematic reviews valuable for surgeons? Answer. They help surgeons navigate a large volume of published studies by bringing together the most relevant evidence and highlighting which findings are supported by higher quality research. Question. What does the Cochrane Library offer to support systematic reviews in surgery? Answer. The Cochrane Library provides a large collection of systematic reviews covering a wide range of surgical topics. Question. How do systematic reviews help surgeons apply evidence to specific surgical patients? Answer. They help identify inconsistencies across studies, determine whether findings apply to specific patient subgroups, and support clinical decision-making by clarifying what the overall body of evidence suggests. Qualitative data analysis. Question. What are qualitative data in surgical research? Answer. Qualitative data are non-numerical data used to describe concepts, opinions, or interpretations. Question. What are common sources of qualitative data in surgical research? Answer. Common sources include interviews, focus groups, document analysis, stated preference research, and observational notes. Question. What is the purpose of qualitative data analysis in surgical research? Answer. The purpose is to identify patterns, generate hypotheses, and provide a deeper understanding of research findings. Question. Which methodologies are commonly used for qualitative data analysis? Answer. Common methodologies include phenomenology, content analysis, grounded theory, and ethnography. Question. What is phenomenology in qualitative research? Answer. Phenomenology studies how individuals perceive and derive meaning from their life experiences. Question. What is content analysis in qualitative research? Answer. Content analysis analyzes textual data to identify frequencies, patterns, and themes within the text. Question. How does qualitative research contribute to understanding outcomes in surgery? Answer. Qualitative research provides a deeper understanding of social and environmental contexts influencing surgical outcomes. Question. What are the strengths of qualitative data analysis? Answer. Qualitative data analysis offers insights into phenomena that are difficult to study with quantitative methods alone. Question. What are common applications of qualitative methods in surgery? Answer. Qualitative methods are used to understand operating room workflow, communication among surgical teams, and information exchange during transitions of care. Question. How were surgeons, nurses, and trainees' opinions and experiences gathered in qualitative studies of surgical care? Answer. Their opinions and experiences were gathered through direct observation of care processes and the technology used during communication. Question. How can qualitative methods be used to explore patient perspectives related to surgery? Answer. Content analysis of patient focus groups can explore psychosocial issues related to surgery, including factors influencing satisfaction with care and perceived barriers to high-quality care. Question. What approaches can improve data quality and reduce bias in qualitative surgical research? Answer. Using relatable third-party interviewers minimizes investigator bias and acquiescence bias, increasing the likelihood of obtaining unbiased data. Question. What is mixed methods research? Answer. Mixed methods research collects and analyses both qualitative data and quantitative data within the same study. Question. What advantages does mixed methods research offer in surgical research? Answer. It allows investigators to define a specific research problem and then use a combination of methodologies to elucidate relevant issues in a broader and more detailed way. Question. What is an example of mixed methods research in surgery? Answer. One example is a study on provider compliance with surgical safety checklists that used qualitative analysis to analyze provider usage and quantitative analysis to explore reasons for compliance or non-compliance. Appraising surgical evidence. Question. What does the evidence spectrum in surgery range from? Answer. The evidence spectrum in surgery ranges from empirical observations to results of well-designed randomized controlled trials. Question. What does evidence-based surgery involve? Answer. Evidence-based surgery involves evaluating the reliability of evidence and choosing practices supported by the best available evidence. Question. What is common surgical practice often based on? Answer. Common surgical practice is often based on empirical impressions and is not formally tested. Question. What is an evidence hierarchy in surgery, and what is it used for? Answer. Several rubrics exist to evaluate and determine the strength of scientific evidence in surgical practice. Question. What is the purpose of an evidence hierarchy for surgeons? Answer. These systems help surgeons judge the reliability of evidence, ranging from the most reliable to the least reliable sources. Question. What guidance is often given to surgeons when choosing which evidence to base their practice on? Answer. Surgeons are advised to base their practices on evidence from studies at the highest levels of the evidence hierarchy. Question. How does the United States Preventive Services Services Task Force Evidence Hierarchy categorize certainty of evidence? Answer. The United States Preventive Services Task Force system categorizes certainty of evidence based on study design and other factors such as quality, consistency, and completeness. Question. What levels of evidence certainty does the United States Preventive Services Task Force assign? Answer. Evidence certainty is assigned as high, moderate, or low based on 6 critical appraisals. Question. Why was the United States Preventive Services Task Force evidence system revised in 2012? Answer. The United States Preventive Services Task Force system was revised in 2012 to address criticisms that the earlier approach focused too narrowly on study design alone. Question. What is the grading of recommendations assessment, development and evaluation system for grading evidence? Answer. It is a structured scoring process that considers study characteristics to determine whether evidence should be downgraded or upgraded. Question. What factors can affect the quality of evidence when surgeons appraise research studies? Answer. Evidence quality can be affected by study design, such as randomized controlled trials compared with observational studies, sample size, effect size, and potential biases such as allocation, concealment, and attrition. Question. What are the limitations of grading systems that rank evidence quality? Answer. No single grading system is perfect, so surgeons must ultimately judge both the quality of evidence and whether it applies to their specific clinical context. Evaluating study quality. Question. What does internal validity mean when evaluating study quality? Answer. Internal validity means the observed outcome is solely attributed to the specific intervention, not to alternative explanations. Question. What does external validity mean when evaluating study quality? Answer. External validity means study results are relevant and applicable to real-world clinical practice beyond the study's specific conditions. Question. What is the difference between efficacy and effectiveness in clinical studies? Answer. Efficacy refers to an intervention's performance under ideal conditions, while effectiveness describes its impact in real-world, uncontrolled settings. Internal validity. Question. What does an internal validity assessment require researchers to consider? Answer. An internal validity assessment requires understanding how bias, confounding, and chance can influence study results. Question. What does chance mean in the context of interpreting study findings? Answer. Chance refers to unpredictable randomness of events that can mislead researchers into thinking an effect exists or does not exist. Question. What is bias in a clinical study, and where can it occur? Answer. Bias refers to systematic errors that arise from how subjects are selected or how outcomes and exposures are assessed. Sources of bias. Question. What is bias in a clinical study? Answer. Bias is a systematic problem in a clinical study that leads to inaccurate estimates of outcome differences between comparison groups. Question. What are the main types of bias described in surgical outcomes and health services research? Answer. The main types are selection bias, which involves errors in choosing study subjects, and measurement bias, which involves errors in data collection. Question. How does bias affect surgical outcomes research and health services research? Answer. Bias affects the accuracy of surgical outcomes research and health services research studies. Question. What is selection bias? Answer. Selection bias is an imperfection in the selection process that leads to a sample that is not representative of the target population. Question. How can selection bias affect estimates of an intervention's effect? Answer. Selection bias can lead to overestimation or underestimation of the effect of an intervention, affecting both internal validity and external validity. Question. In what situations does selection bias commonly occur? Answer. It frequently occurs in observational studies where selection of treatment is influenced by unmeasured variables. Question. What is measurement bias? Answer. Measurement bias refers to problems arising from how outcome data are collected, which can lead to inaccurate results. Question. What are examples of measurement bias in surgical research? Answer. Examples include differences in reporting based on interview compared with anonymous survey, and surgeon assessment compared with hospital epidemiologist reporting. Question. How can researchers mitigate measurement bias? Answer. Researchers can mitigate measurement bias by blinding participants and outcome assessors to the intervention and by employing prospective study designs. Confounding. Question. What is confounding in clinical research? Answer. Confounding refers to differences in outcomes that occur because baseline risks are unevenly distributed between comparison groups. Question. What are confounding variables, and how do they create misleading results? Answer. Confounding variables are factors that influence both the exposure and the outcome, which can create a false association between the exposure and the outcome. Question. Can you give an example of how confounding might appear in surgical outcomes research? Answer. One example is comparing mortality after open colectomy compared with laparoscopic colectomy, where differences in illness severity could confound the results. Question. Why is confounding considered a potential source of error in research studies? Answer. Confounding can mix the apparent effect of the primary variable of interest with the effects of other variables, making it difficult to isolate the true relationship. Question. How can confounding be minimized through study design and analysis? Answer. Confounding can be minimized through study design, for example by using randomization, and through analytic methods during data analysis. Question. How does randomization help reduce confounding in a study? Answer. Randomization helps evenly distribute confounding variables across comparison groups, reducing their influence on the study's results. Question. What does restriction mean as a study design approach to control confounding? Answer. Restriction controls confounding by limiting study participants to a specific group so that certain confounding variables are held constant. Question. What is an example of restriction in a surgical study? Answer. One example is enrolling only patients undergoing elective surgery and excluding patients undergoing emergent procedures. Question. What is a limitation of restrictive entry criteria when using restriction to control confounding? Answer. Restrictive entry criteria can limit generalizability because the study population may no longer represent the broader patient population. Question. What does matching mean as a method to avoid confounding? Answer. Matching uses a comparison group of unexposed subjects who are identical to exposed subjects across a set of characteristics, reducing confounding by balancing those characteristics. Question. How can confounding be addressed during the analytic phase of a study? Answer. Confounding can be addressed during analysis using statistical risk adjustment techniques. Question. What is multivariate regression, and how is it used to control confounding? Answer. Multivariate regression analysis is a common technique for controlling confounding, including linear regression models and logistic regression models. Question. When should researchers use logistic regression, and when should they use linear regression? Answer. Logistic regression is used for binary outcome variables, while linear regression is used for continuous outcome variables. Question. What are limitations of statistical risk adjustment when controlling for confounding? Answer. Statistical risk adjustment can address only recognized confounders, and adding too many variables can decrease statistical power and increase the chance of false negative findings. Question. What sample size requirements should researchers consider when building regression models? Answer. Regression model estimates can be unreliable when there are few outcome events. Logistic regression commonly requires at least 10 outcomes per variable, while linear regression commonly requires about 10 to 15 outcomes per variable. Question. What is overfitting, and why can it be a problem in regression models? Answer. Overfitting occurs when too many variables are added and the model becomes too closely fitted to the training data, which reduces its ability to generalize to other patient populations. Question. What additional techniques can be used to control confounding besides regression models? Answer. Additional techniques include stratification and propensity score risk adjustment. Question. What is a propensity score? Answer. A propensity score is a single numerical summary of observed confounders that predicts the probability that a patient will receive a treatment. Question. How are propensity scores used in observational studies? Answer. They can be used for stratified analysis or for matching cases and controls in observational studies. Question. What is instrumental variable analysis, and how can it limit confounding? Answer. Instrumental variable analysis limits confounding by comparing groups that differ in levels of a third factor, called an instrumental variable, which is strongly correlated with the exposure but does not independently affect the outcome. Question. What is an example of instrumental variable analysis in health services research? Answer. One example is studying the effect of catheterization on mortality after myocardial infarction by comparing groups of patients who live at different distances from hospitals that provide these services. Question. What key assumption must hold true for instrumental variable analysis to be valid? Answer. A key assumption is that potentially confounding factors are randomly distributed geographically, and that geographic distance affects mortality only indirectly through its correlation with access to treatment. Hypothesis testing. Question. What is the null hypothesis in a clinical study? Answer. The null hypothesis is the assumption that no difference exists between treatment groups in a clinical study. Question. What is a type 1 error in hypothesis testing? Answer. A type 1 error occurs when the null hypothesis is incorrectly rejected, leading to the conclusion that a difference exists when it does not. Question. What is a type 2 error in hypothesis testing? Answer. A type 2 error occurs when the null hypothesis is incorrectly accepted, leading to the conclusion that no difference exists when a difference actually does exist. Type I errors. Question. What probability value threshold is conventionally used to indicate statistical significance? Answer. A probability value of 0.05 is conventionally used as a threshold for statistical significance. Question. What does a probability value represent when comparing groups in a study? Answer. A probability value represents the probability that observed differences between groups are due to chance. Question. What does statistical testing quantify about the risk of a type 1 error? Answer. Statistical testing quantifies the likelihood of a type 1 error, which is the incorrect rejection of a true null hypothesis. Question. When does a type 1 error occur in hypothesis testing? Answer. It occurs when a research finding is falsely deemed statistically significant. Question. What practices can increase the risk of a type 1 error? Answer. Unspecified research questions, multiple statistical tests, or numerous comparisons without adjustments can increase the risk of a type 1 error. Question. How can researchers reduce the risk of a type 1 error when making multiple comparisons? Answer. Researchers can use the Bonferroni correction or the Hochberg sequential procedure when multiple comparisons are involved. Question. What is a confidence interval? Answer. A confidence interval is a range of values that likely contains the true mean of the population. Question. How should a confidence interval be interpreted? Answer. It represents the range of observed differences expected if the study were repeated infinitely. Question. What factors influence the width of a confidence interval? Answer. The width is influenced by sample size, confidence level, and sample variability. Question. What criteria should be considered when selecting an appropriate statistical test? Answer. Criteria include the number of observations, the number of groups, the type of comparison, the type of data, the distribution of the data, and whether risk adjustment is needed. Question. How complex are the study designs and statistical tests used in most surgical outcome studies? Answer. Most surgical outcome studies use simple designs and statistical tests that are understandable to non-statisticians. Question. What is the purpose of statistical tests in surgical outcomes research? Answer. Their purpose is to calculate probability values and confidence intervals. Type 2 errors. Question. What is a type 2 error in hypothesis testing? Answer. A type 2 error occurs when the null hypothesis is falsely accepted because the study does not have a sufficient sample size to detect a true difference. Question. What is statistical power in a clinical study? Answer. Statistical power is the ability of a study to detect a true difference in outcomes when a true difference exists. Question. Why is a power calculation important before starting a study? Answer. A power calculation is essential to determine the minimum sample size needed to detect a meaningful difference before the study begins. Question. How should surgeons interpret studies with null findings when there is no power calculation? Answer. Surgeons should be cautious, because without a power calculation it may be unclear whether the study truly found no difference or simply lacked the ability to detect one. Question. How can an after-the-fact power analysis help when interpreting retrospective studies with no statistically significant effects? Answer. An after-the-fact power analysis can help determine whether a study may have failed to detect an effect because it was underpowered rather than because no effect exists. Question. What makes non-inferiority studies different from studies designed to identify a difference? Answer. Non-inferiority studies use specific methods and decision thresholds to determine whether one approach is not unacceptably worse than another, rather than aiming to show a clear difference. Interpreting and applying evidence to surgical practice. Question. What does an external validity assessment determine when applying research evidence to a surgical decision? Answer. It determines whether study findings are applicable to a specific clinical scenario. Question. What does internal validity confirmation ensure when interpreting a study? Answer. It ensures the observed outcome is due to the the intervention and not alternative explanations. Question. What does applying evidence in surgery require clinicians to assess before changing practice? Answer. It requires careful assessment of both internal validity and external validity of studies. Question. When assessing external validity, what key elements of a study should clinicians consider? Answer. Clinicians should consider the patient population, the intervention, and the outcomes that were measured. Question. How can differences between a study population and the target patient group affect external validity? Answer. If the study population differs from the patients a surgeon treats, the findings may not apply well, reducing external validity. Question. Can you give an example of how external validity can be limited by an older study population? Answer. A Veterans Affairs study on hernia repair may be well designed, but it may not generalize to younger patients because the study population is older. Question. How can selection bias affect the generalizability of study results? Answer. Subject selection bias can negatively impact the generalizability of study results. Question. What does the asymptomatic carotid atherosclerosis study illustrate about selection bias and perioperative mortality? Answer. The asymptomatic carotid atherosclerosis study enrolled younger and healthier participants and reported lower perioperative mortality than the general population, highlighting how selection can bias results. Question. How might the asymptomatic carotid atherosclerosis study findings limit generalizability to other patient groups? Answer. The findings may apply more to younger patients with asymptomatic carotid stenosis than to older or higher-risk patients because the study population's characteristics differ from the broader population. Conclusion. Question. What does evidence-based surgery mean in the context of surgical decision-making? Answer. Evidence-based surgery means applying research evidence directly to surgical decision-making. Question. Why is interpreting the literature important for surgeons? Answer. Interpreting the literature is important because surgeons need to appraise evidence strength and research quality to make informed decisions. Question. Why is collaboration important for producing high-quality surgical science? Answer. Collaboration is important because partnering with experts in clinical trial design and data analysis helps develop and disseminate high-quality surgical science. That's it. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.